We're Spanish scientists in the USA, of course, in Spanish. And we are professionals that work in science and technology, and also in fields of education and communication, and also in administration within those fields of science and technology. In our members, we have also people that don't work in these fields, but like ECUSA, like the project and the goals, and we like to advocate and support us. In ECUSA, we have maybe it's like a battery. In ECUSA, we have a mission that we are fulfilling with a number of goals. Our mission is to create a network of scientists and people working in technology in order to help with the professional development and to facilitate the interchange of ideas and the collaborations between these professionals. We also have, as another goal, to increase the awareness of science and technology in the general public. And we are doing this via seminars, like the one from today from Mariana, and also by going into the schools and promoting science and technology fields in kids. Our last objective is to serve as a point of contact for all public and private institutions that would like to contact us, including governments and mass media, that may need advice from our members. So this is our last objective. To fulfill all of these objectives, we have a number of people that work for us, that work in ECUSA. We are around 70 people in 4 or 5 chapters now in the USA, in Boston, New York City, Washington, D.C., California, and also Midwest. And these 70 plus people are working to create the programs and to implement them so that you can actually benefit from them. I had a slide with everybody that was in the Boston chapter, and I hope that eventually we get the slides also that I can show you the faces that are here. And you guys can raise yourselves up.
What slide did you want?
Stand up. Come on, guys, don't be shy. Don't be shy. We have all the people outside. So these are part of the people that are working to make ECUSA what it is. They really work really hard. They have full-time jobs. They have full-time jobs. Oops, sorry. All right. Let's keep all of this. I didn't realize that this was. And on top of their jobs and all the associations that they belong to, they have the time to do all of this for you. As I told you, we are right now in, we have over 600 members in more than half the states in the United States. It's working not too well, actually, but I don't want to relate too much the talk from today. So anyway, yeah, yes, you can just go to the talk, see if you guys can figure this out, and I just finish saying about it. Among the activities that we are organizing in Boston are activities related to public outreach and education, like the one from today. We have a program of ECUSA in the schools where people want, when they have to stimulate the kids to, how do you say, become professionals in the STEM fields, that stand for science, technology, engineering, mathematics. Also, we have a program that is starting now to reach Spanish kids with American kids and exchange science, technology, English, and education, society, so on and so forth. Within professional development, that is actually the plan that I lead within ECUSA, we have a number of activities. We have a mentoring program that will start next year, and it's a mentoring program to help people that are trying to move out of the postdoc or training part of their career into a professional career to basically get a job. We have also, we are preparing a welcome package that is a series of instructions, quote unquote, on how to survive in the USA when you first arrive. So we are trying to give this to students and postdocs that will come to the US and to prepare them for what is to come. We have a program that is science to industry, that is an overarching program between 3 or 4 of the commissions that we work in ECUSA. And if somebody wants any more explanations, I can give them to you later. And we also have given seminars about professional development, networking, and also workshops into how to prepare for a job and interview here in the USA. In addition to this, there's a commission of communities preparing what is called a guide of experts that contains all of the members of ECUSA and where they work, so that we can use them to find positions, to find collaborators, for the press to find you if they need some type of information. And somewhere there was a slide at the end with our address and everything. If you would like to become members of ECUSA, it's to be a full member, it is $30. It's not too much a year. You can also be an associate member. Only the members will have the right to attend some of the things that we organize at the mentoring program. So please join us. So these are the things that I just mentioned. Oh, I forgot. TMPM Hamon is our networking program here in Boston. As you can see, as you know, we meet in one of the bars here in Cambridge, and we really have fun meeting other people, establishing collaborations. In fact, one of the programs that I am leading in professional development came from finding somebody or meeting somebody in one of these networking events that Joaquin organizes. And I think the next one is our address and everything. So if you would like to join us, please.
Oops, sorry.
Yeah, that's it. This is our ECUSA.s membership. Become a member. If you would like to volunteer or have suggestions about what we could organize, please do email us at boston@ecusa.s. And without much ado, I'm going to introduce our speaker of today. It is a privilege, actually, to have Mariana Castells. Mariana is a clinician, a researcher, and a teacher. Everything in one package. She is working at the Brigham and Women's Hospital in the Rheumatology, Immunology, and Allergy division. She wears many hats. As a clinician, she's attending at the Brigham and Women's Hospital, where she holds the position of director of the Drug Hypersensitivity and Desensitization Center. She is also the associate director of the Mastocytosis Center, and she participates in preclinical trials. As a teacher, she gives both formal and informal rounds, and also teaches students, fellows, and residents at the Israel Hospital, the College Center, Children's Hospital, the Brigham and Women's, and also Wesseman Medical School. In addition, and it's something that is close to my heart, she's also involved in professional development. She works in projects such as Patient, Doctor, and Preceptor Student Project, the Mentor Clinical Casebook Project, and the Career Development Project at the Brigham and Women's Hospital. In addition to all of this, she is also the director of the Allergy and Clinical Immunology Training Program, where she oversees all of the aspects of the programs, from admissions, teaching, organizes courses, establishes the rotations for clinical and research for fellows, and also evaluates their progress. She is also, within that role, she is also the chair of the annual training program directors assembly of the American Academy of Allergy, Asthma, and Immunology. And it makes me very proud that this party is actually the chair of this assembly. Dr. Castell is also known for her research, in which in her laboratory she is determining how desensitization occurs and how we can use proteins in our body to help the process of desensitization. Her activities also have a base in Spain, where she is the director of the International Drug Desensitization meeting in Barcelona that happens every fall since 2011. This program brings 100 professionals of medicine, from allergists to oncologists, to pediatricians, and other specialties from Europe and South America and North America. Of course, it has been awarded a number of awards and prizes, and they are too long to go through. Her CV spans 32 pages, as you can imagine. And really, we are really privileged and honored to have you here, Mariana.
kind of interest you or pick your interest in two things that are important in our society, which are food and medications in this 21st century. And I say the two is on site because in my research laboratory and in our hospital and at the Harvard Medical School, we have been doing a lot of investigation about those. So what I want to do is give you an overview of what the problem is and then introduce you to what are the possibilities and then what can we do. So I am a consultant for a lot of places, including the NIH and the Food and Drug Administration. So let me just see if I can do this with the pointer work. Yes, yes. So everybody knows somebody who has a food allergy. I'm sure that within you, how many of you are either food allergic or know somebody who has a food allergy? There you go. At least, almost half of you. So we have this thing about the hygiene microbiome hypothesis that when, Cro-Magnon and Lucy 3.5 million years ago, we had a lot of infections that promoted a healthy immune system. And now there is this thing that the microbes that we are encountering now are not as strong as the infections that we had before, so the immune system is quote-unquote a little bit bored. And so exposure to environmental organisms and asthma have been linked in more recent years. So the epidemiology says that 4 to 6% of kids can be allergic to all those things, particularly in the United States peanuts. But if you look at, for example, Spain, it would be fish or some other proteins. In adults, it's slightly lower, but shellfish and fish. And it's really hard to study that because we can't do all food challenges on everyone. And there is a self-reporting bias. Somebody says, I'm allergic to this and that. Well, is that really true? Can we say that? So I will show you data that shows that there is a similar prevalence throughout the world, so mostly the developed world. So we have actually some risk factors that we don't know about and that we encounter every day. So there's an influence suggesting that it's increasing, more people are affected, and there's a long time to outgrow allergy. So this is something that we have put together in very recently. So food allergy prevalence in recent years. And you see here that we talk about Caucasian populations, African American populations, Hispanic populations, and you see here the risk, 0 to 8%. So all the curves are going in the right direction. We are getting allergic and more allergic. And you see here that, for example, in this population of African Americans, the increase in allergy, in food allergies, is major as in others, but everybody has an increase, and some populations are more targeted than others. How persistent is the food allergy? So we said, well, egg allergy, the kids have an egg allergy, they may outlive the egg allergy. Well, not so much true. We have, if we, depending on how you define egg allergy meaning you have an egg, raw egg, cooked egg, something who has egg. So this can be as long as 18 years. So the median outgrowth that we used to say, well, children, when they have food allergies, they can outgrow that very easily. No longer. We are taking much longer to outgrow this. And there's something that is important, is that we know that something that's called specific IgE, which is a blood test, are associated with outgrow time. So the higher that number, like we see here, the prevalence of the food allergy, the longer will persist. The ones that have lower of that IgE, that will go and disappear much quicker. So we have now in the 21st century ways in which we can measure how long those allergies are going to be persistent. And what are the manifestations of food allergy? So the typical would be that within seconds to minutes, people say, oh, my mouth is kind of itchy, I feel a little bit of nauseating, so it could be a rash, and then maybe sneezing, maybe coughing, and the worst case scenario is passing out, what we call an anaphylaxis. So that is the sequence. And some people will just stop here, but there is a risk that this sequence can be gone to the end of it. And so how can you actually prevent that? How can you actually be aware of that? So testing is not perfect. So many people can actually have what we call a skin testing or that IgE to peanut, and they are sensitized, which is about 9% of the USA population. But then only 3% have actually what we call clinical symptoms of allergy. So, and many positive kids, when they outgrow the allergy, they continue to have those tests positive. And in some very few, but in some negative persons and kids, they're still reactive when they have more numbers. So the testing is not perfect. So that's one thing that we know. So we have now improved the ways that we look at the food allergies. So measuring this IgE is important, but we have now known that is what we call component result diagnostic. So a peanut is made of 27 proteins, and one of the proteins I would call it, we call it ARA or arachis, the Latin name for peanut. And so ARA 1 to 9 is what we can measure in the peanut. So people who are allergic to that ARA 2 are associated with the most severe clinical allergies. So we are learning that if we can differentiate if people are allergic to ARA 1, 2, 3, 4, 5, 6, 7, or 9, we can define which ones are more associated. So that is really a step forward, and that seems to be panning out in many populations, which is that ARA 2 is the one that's associated with more severe allergies. Then we also know that food allergy and the microbiome is very important. We have known that specific microbes and exposures might alter the microflora and are associated with an increase in those food allergies. For example, we did not know that, but cesarean section can increase food allergies. So the kids that are born to mothers with cesarean sections have more food allergies. Early birth order, so the oldest kid in the family is more allergic than the last one. Daycare, when the kids go to daycare, is associated also with food allergies. Farm lifestyle is associated with less allergies. Animal exposure, endotoxin exposure. So all of those things have been given a one order for the development of food allergies. So you might say, well, I would like not to develop food allergies. What can I do? And we said, well, there's nothing you can do at the present time, because there's many hidden ways in which we can become allergic to foods. So antimicrobial chemicals, and you can recognize even things that you use, your toothpaste, any personal care products, cosmetics, they have what is called triclosan, parabens, and all those things now have a function that's called an endocrine disruption function, and they have antimicrobial activity. So we are cleaner, definitely, and everything smells well, but what happens with that? Desensitization. So if we look at triclosan and we measure that in the urine of kids, boys and girls, the kids that develop food allergies are kids that have more triclosan in their urine. So this is a new thing that we didn't know, that was just recently unfolding in the last couple of years, that products that we encounter in the daily living can actually be associated with the development of food allergies. So this is all of me. So we have 10 to the 13 human cells, but in our microbiome we have 10 to the 14. So we are full of microbes. And this is actually the new era in this 21st century of very important understanding of how are we shaped, how do we develop diseases. And the way we develop diseases, the current thinking is that we have a microbiome. Depending on how the microbiome was constructed, we are going to be diabetic, hypertensive, we're going to develop food allergies, we're going to develop any other diseases. And this is something that we have very actively been working. So this kid here, who is being licked by a dog, may actually not develop dog allergies. So it's actually quite good. And this kid who has a lot of microbes from the tongue of the dog may actually be a kid that's going to be extremely healthy. So we're going to kind of break the paradigms that we wanted to be a very clean society, and suddenly we're found that that clean society has a lot of things that go in terms of developing diseases that we really didn't want. And we had not realized that that would be possible. So the microbiome is the presence of bacteria in the small and large intestine. So we have a number of bacteria that are actually good bacteria. They shape the way we have our intestines, they shape our reactions, they create those mucus layers, and that's how we are actually healthy. So if we create an antibiotic, like microbiota, so if we take antibiotics, we deplete that for a prolonged period of time, then the interactions inside the intestine, inside all the gastrointestinal tract are different and lead to allergic inflammation. So that is shown very nicely with mice. So we take mice that are germ-free. We have those little mice here. They don't create what we call B cells, which are the early B cell lineage. But if the mice are housed with other kind of dirty mice, they create a lot of the B cells. So those B cells are critical to develop a healthy immune system. And those experiments have been done in our division by Wesseman, showing that the expression of those very nice cells that would actually be protecting us against bacteria, viruses, and all the environmental bad guys do not exist when we use germ-free or antibiotics. This is the funny slide. So now we can donate your food. So let me elaborate a little bit more on that. So there are people who are very healthy, don't have autoimmune disorders, they don't have diabetes, they don't have hypertension, they don't have any diseases, they don't have cancer, and they have very, very healthy food. So if you are somebody who, or you know somebody who has any disease, autoimmune disorders, rheumatoid arthritis, hypertension, diabetes, cancer, the food is different. So we are, and a lot of other investigators are very fascinated by creating a food that would be the extremely healthy food. So if you actually take twins that just have from the same mother and raised in the same place, and they are in the same city like Boston, and one moves to China, if it comes back, the food will be completely different. So the environment shapes the food. And now, at the present time, you can donate to food, and you can actually follow this, and then they will be able to do the genome of that food. And that's very important because we're trying to classify, what are the good bacteria in that food, what are the things that we need. The other thing is we have started to do transfers of food. And I just tell you that this is, being in the medical arena for the last 3 years. The first time I had a patient in front of me, and she was having a lot of diseases, and she was telling me I feel terrible, and I have this diarrhea, and she suddenly said to me, "Can you do food transfer?" And I thought she had lost her mind. I said, okay, let me think about it. I thought maybe she had a stroke or something. So I quickly went to my colleagues and I said, "Guys, have you heard about it?" "Oh yes, the microbiome. I think that there's somebody." So I had to educate myself 3 years ago. Now it's a common process. Somebody gets into the hospital, they have a problem with diarrhea because they have super infections. They can have a transfer of the food of somebody in their family who's very healthy. And that's something that's occurring today. So just for your knowledge, this is something that is available. The current treatments for food allergy, what it is, well, avoidance is difficult. If you have a food allergy, it may have a major impact on your quality of life. A kid who is allergic to peanuts, nobody in the household can bring anything close to peanuts. Giving a kiss to somebody who ate a peanut butter sandwich can actually provoke a very severe allergic reaction. So that is very important. It also can create significant nutritional risk for people who have very wide allergies. It's very difficult. So wait for the allergy to be outgrown. Well, like I said, 18 years, that's difficult. So we have now, and I just wanted to tell you about kind of the new approaches for food allergies. There is a new antibody that's called Xolair that removes that bad antibody, that's the IgE. There is a lot of work in the Chinese herbal formulas. They have a fantastic potential for removing the allergies or changing them. There is something that's called immunotherapy. So desensitizing children to egg, to milk, to peanut, by giving them small amounts. And that is something that's currently being done in our hospital, at Mass General Hospital. And one of the ways is to heat the milk and the eggs. So that is possible. So the Omalizumab is that anti-IgE that I was telling you. So when the patients are starting, they can only tolerate half a peanut here. when they are on this medication, they can tolerate 20 minutes. So really, it changes dramatically. Not tolerating half a peanut is a dangerous thing. But tolerating about 20 peanuts, you can go into an airplane, you can be in any place where the peanut can be hidden, and you can ingest that. So that makes a big difference. The approach to the food immunotherapy that I was telling you is that those patients who want to undergo egg or meal or peanut immunotherapy, they are given a small amount in increasing doses over several weeks, and then they have to eat that every day, and then they do that at home. And when the kids or the adults can reach the maintenance level, which can be maybe a glass of milk, a muffin with egg, then they can tolerate their egg subsequently. So, like we said here, at baseline they don't tolerate, and the oral immunotherapy permits them to tolerate big amounts of the food. So, one of the things that I wanted to show you in terms of change of paradigms, the guidelines for the Pediatric Association here in the United States, and pretty much in a lot of other places, say that kids, when you have a kid, you cannot feed that kid peanuts for 3 years. So they should not be fed peanuts because there is a risk of developing peanut allergy. So people in England and in Israel say, I don't understand that. In Israel, for example, in other countries, they feed peanuts the minute they are born. When the kids are 2 days old, they put a finger with peanut, and then the kid licks that, and nobody is allergic to peanuts. So how could that be? So they underwent a big study that is called the LIP study, which is a randomized trial to peanut consumption in infants at risk of peanut allergy. And because of the prevalence of peanut allergy is so high, it has doubled in the past 10 years, and it's becoming prevalent in Africa and Asia, they wanted to evaluate the strategies. Should we continue to say no peanuts, or should we kind of modify that? And so they randomized 640 infants with severe eczema and egg allergy or other, and they told those kids either to eat peanut or not eat peanut. And what happened is the prevalence of peanut allergy at 60 months was 13.7 in the group that avoided, and 1.9 in the group that ate. So we were completely wrong. All the kids that were actually fed from day one a little bit of peanut did not become allergic. So this is like a big deal, and it was published just a few weeks ago in the New England Journal of Medicine, and everybody is looking at that. The American Pediatric Association is trying to change the guidelines. American Medical Association for Adults is also changing guidelines, so we are in the process of revisiting that. But I want to leave you with the notion that this changes the paradigm. If you have children, if you want to have children, if you are allergic to foods, there are ways in which we can act upon. The first one is, if you're pregnant, don't stop eating whatever you want. And if you have little kids that were born a few days ago, a few months ago, a few weeks ago, just give them peanuts because they will not become allergic. So that's kind of my overview of the food allergy, and I think that just eating peanuts and not eating peanuts, so the people who become, the kids who become allergic to peanuts here are the ones that are in the avoidance group. You see the blue ones. Practically very few of them who started to eat peanuts become allergic. And that's a startling result. That's a paradigm changing, and that will, and here you see that those people who did not eat peanut, the peanut avoidance, will continue to be very allergic. All those things is when they put a little bit of peanut here, they become extremely allergic. And here is the good protective antibodies only came when people had consumed peanuts. So from the immunological standpoint, the people who continue to eat peanuts or started to eat peanuts become completely protected against peanut allergy. So I want to switch gears a little bit. So peanut food allergies is important, but we have also developed a little bit of something that's called drug allergy. Who does not know somebody who has like a penicillin allergy or a drug allergy? Anybody? Yeah, I mean, fewer than food allergy, but you know people who have food allergy, drug allergy. So cancer patients survive longer, and they are exposed to multiple chemotherapy treatments. So that's really, there is very good treatments for cancer now, but the patients are exposed to a lot of those. And then people who have what we call chronic inflammatory diseases also have new medications, monoclonal antibodies, biological agents. Kids with cystic fibrosis, they live longer. Patients who have asthma may become allergic to aspirin. We have women who have what we call progesterone autoimmune dermatitis. They cannot get fertile because they have an allergy to or progesterone. And so we have an increase in all those allergic diseases nowadays. So it is more and more prevalent. So penicillin allergy, to put an example, is thought to be 10% in the population. But in reality, when people come to our clinics and we do the penicillin speed testing, 90% of those people are not allergic. They have a negative speed test, we feed them a little bit of penicillin, so 50% lose the penicillin allergy after 5 years, 90% lose it after 10 years. So it's a misconception that penicillin allergy is carried throughout the life. So the best avenue for somebody who says penicillin allergy is go see an allergist, go see somebody who can do that. There are allergies to medications that are kind of severe. So here is a way to diagnose allergies. We have patch testing, and we have here something that is used for HIV that has a very severe hypersensitivity reaction. And we have known that some patients are allergic because of their genes. So some patients have what we call HLA alleles, and they develop that drug hypersensitivity. So for example, for that medication that's called abacavir or carboplatin, this is used for seizures. This is a very important medication for seizures, and this is used for HIV. They become allergic to that because they have a specific genotype, and that we cannot change. So people, there's genetic determinants for drug allergy, and that's important. But what's important about that is we didn't know, and now we know. So we can actually genotype people. So you see here before genetic screenings, about 22% of the people who took that abacavir would be allergic. But when we genotype, it has eliminated hypersensitivity reactions. What is the prevalence of that? So the genotypes are different around the world. But for example, in the United States, we have up to, in the African American, 2.5% of people are allergic to this genotype, which are like 5701. And for example, in other places, like in Thailand, up to 10%. So genotyping is extremely important for drug allergies nowadays. And that's a new field also. So what I tell my students is in the future we will come with our little bracelet with our genotype here, and we will scan it, and then in the computer, and we'll say, you can take this, you can take that, you cannot take this, you cannot take that, because the genotype influences that. And I just wanted to dwell a little bit on what we call desensitizations, because this was sent to me by somebody in Austria in 2014. So this is somebody who does not know me, sent me an email. My mom, very nice, 57, she has cervical cancer, she's treated with chemotherapy, that's the medication, and then she developed a very severe reaction. And the doctor said, there's nothing we can do about that. You know, your mom cannot take that, maybe she'll live a little bit less. Well, the guy was, I don't want my mom to not live longer. So she stumbled upon a paper that we had published, and she said to me, you suggest that desensitization may be possible, so can you recommend that be done? And the reason I'm showing it to you is that we sent a protocol to them for that desensitization, and we did that on Skype. So, this wonderful 21st century, we did not need to go to Austria, and they did not need to come to Boston. And so they did the desensitization that we proposed. The mother had the MRI, and she has actually successfully applied the protocol for the first time in Austria in 2014. And she has now survived, and she's in remission after we did the desensitization. So again, the power of technology is incredible. The field that I have worked most is called desensitization. And what I have to try and attempt to do is to reintroduce the medication that people who have had severe reactions need the most. So those are reactions. You can see somebody who has here hives, is itchy, is swollen, a lot of rashes here, different types of reactions. And you could say, okay, could you avoid the medication? But like in food allergy, it may not be possible. But even if it were possible, it's It's also possible that the lifespan, as this guy was saying, may be reduced if we don't use the medication, or the quality of the life of that person may also be reduced because we don't use what we call first line therapy. So we have developed this, and this is a young girl from a 16-year-old in Children's Hospital. She had a very big lymphoma here. She was playing soccer. They gave her, she lost consciousness with the ball, and then she had an MRI. She had a big lymphoma. She was started on methotrexate, which is the drug of choice for her aggressive lymphoma, and then she became deadly allergic. So the oncologist again said, can't take that no longer. We indeed this protocol, which has 16 steps, and it worked actually. It worked very well. She's in remission. So we have an in vitro model, and I don't want to bore you with that, but what I want to tell you that in the mice that we use for our experiments, if we give a drug antigen, the mice cells, they release histamine, which in the humans, it would be like exploding with an anaphylactic physiologic attack. If we use a desensitization protocol, which is here, then nothing happens. So before, this is called translational research, so we proved it in cells, in mouse cells. We did not even go to the animal model, and we went to humans. And the protocol that we use for that actually is the protocol that we use at the brigade to do that. So we divide the medication that the patient needs in 4 different bags, or 3 different bags. For high risk is 4, for a lower risk is 3. And we administer the medication to those patients, and the safety of those desensitizations we have published it is unprecedented. So it has, no reactions, very mild reactions. So if you can imagine somebody who has had a very violent reaction now can receive the same drug with no death and no reaction. And we just submitted a paper on 2,177 cases. So this protocol is really very useful. So for the ones of you who know somebody who has a drug allergy, we have desensitized to all the chemotherapies, all the drugs that are used for autoimmune disorders, monoclonal antibodies, antibiotics, enzymes, iron, aspirin. And then our project now, and maybe for another conversation, is women who have infertility might be allergic to their progesterone, and we are now desensitizing them. And we have 3 women who have become pregnant under the protocol. So that's that. And those are some of the lesions that those women have every month. And this was Alicia, in fact, a Spanish doctor who came to Boston in 2011. We wrote the initial paper with her. And for people who have aspirin, also, and they have asthma and aspirin, there is a desensitization that actually can be done. And those people have nasal polyps. They cannot smell, and that's very important, and they have an aspirin sensitivity. So the outcomes of those desensitizations that I showed you are really outstanding. Thousands of cases have never had any death, and I would say that I try to do that in the most safe way possible. So the concept is a novel concept. We're allergic to something, very deadly allergic, we can still take it. But how do you take it is what makes a big difference. So those desensitization protocols are tailored to the patient, the reaction. Everything is driven to personalized medicine. We don't have, people ask me, can you give me the desensitization protocol? I remember that when we published the initial paper, this is the chief of the Brockton Hospital in London saying, hey, Mariana, he doesn't know me, but call me for first name. I love your protocol. Can you send the protocol to me? I have a lot of cancer patients who have allergies, and I would like to use it. And I said, okay, how many allergies do you have in your big cancer center? Because we are the ones who understand about it and who could help you with that. Oh, we don't have any allergies, immunologies. And I said, well, I'm not giving you my protocol then. Because, that was the end of our conversation. I heard, later on that he is now hiring an allergist who will be helping with that. But the safety is what's most important for that. The next thing was the efficacy. If somebody is allergic to a drug that's treated for the cancer, is the cancer going to respond to that drug? And we have very, very good data to say that the cancer patients who are desensitized have similar or better life expectancy because being allergic seems to help their cancer. Patients with chronic inflammatory diseases, they have tremendous increase in quality of life. Patients with cystic fibrosis, they can actually take all their antibiotics. Patients who have intolerant, aspirin intolerant patients can as well. And patients who have this progesterone estrogen allergic can conceive. So, and the costs are really not superior. So this is our team. We have collaboration with the Dana-Farber, with Brigham, and it's at Harvard Medical School. We have the nurses, the attendings, the fellows. So it's not my work at all. It's the work of a tremendous team of people who make this possible. And as Isabel was saying, we every year we do this. Now we are going to do that every 2 years because it's really a big undertaking. But I keep my roots with the city where I was born, which was Barcelona, and I am not a secessionist. I will say that from the bat. I'd like to remain, but maybe I'll be killed because of that, you know. And I do speak Catalan, so it's not because, you know, I've been so many years in this country. I do speak Catalan and I love that. So we have a lot of ties with Spain, and we love to remain in that way. So I will finish here, and I'd be happy to answer any questions. Thank you.
I wanted to ask you, how come African Americans have a more tendency to manifest allergies that we were talking about at the beginning of
Well, we do have, I'm sorry. That's an important question because the question is which are the populations that are targeted for those food allergies, drug allergies, and we don't have yet an answer. Processed foods, fast foods, all the foods that contain those oils that are, you know, are populations that also, I would say, we have found the same in people who go to different environments. When they go to Puerto Rico, for example, which has a tendency to have more price, but again, we cannot put the blame only on that. We think that exposure also to other things and the interplay of the genes with the environment is what makes that interaction. So we cannot say, we think that lifestyles, you know, Mediterranean lifestyle is something that people have a tendency to say is better, but we also think that now there's a lot of mercury in the fish that we eat in Spain, and there's a resurgence of cancer. So I cannot say that even if we put a very nice and healthy diet, we're going to know what we eat.
Absolutely. That's very nice, very interesting. I had no idea about allergies. So, do you think...
I'm glad about that. Somebody who doesn't have allergies.
Do you think this can be applied to other kind of allergies, like to pets or animals, these other type of allergies that not necessarily having a sure type?
So food allergies, drug allergies, and when we talk environmental allergies, so the environmental allergies are pet allergies, pollen allergies, dust mite allergies can be treated exactly the same. So we have protocols for desensitization or immunotherapy that are applicable. So for example, I had somebody who had a cat allergy, could not go to the girlfriend because she had 3 cats, and started to cry and wheeze, and that was terrible. We put the guy on shots, and he now can't tolerate the cats. So that,
I always have problems with people coming over.
So the principle is very similar, and like I had mentioned at the beginning, the mast cells and the IgE are the cell type and the molecule that are involved in those allergies, and it's universally for everything.
I have another question, sorry.
Sure.
So how can you explain then when you become allergic because of the contact? So people who work with mice, and then eventually they will become allergic, so they cannot work with them. So it seems like the other inverted process.
Well, so if kids are born in houses where there are dogs, they don't become allergic to the dogs. But if the kid is in a house where there's no dog and then it's got like dog coughs, they might become allergic because of their genes. So there is like, again, the interplay between the genetic inheritance of quote-unquote allergic genes and the presence of those environmental cues. So that's a common problem in my laboratory. People who work with mice, they end up developing the aerosolizing the way in which this becomes more common. So the aerosol of the proteins and the albumin of the mouse is very sensitizing, and people who have allergic genes, and there's a familial determination of that. So families are allergic. So the mother, the grandparents are allergic, so the kids inherited allergic genes. Yeah, there's somebody back here.
Yes, allergy. And I am very curious about the genetic components, which you mentioned there, the HLA, I don't remember.
B5701, yeah.
Yeah, is it also identify the genetic components that generate or are associated with food allergies? And if so, is there anything to do with for those people that are genetically allergic to food?
That's a very important question. So what is inherited in families is what we call the atopic genes. And the atopic genes it's not one gene, it's polygenic. So there are polymorphisms of something that's called IL-4 or an IL-4 receptor, IL-13. So there are many genes that put together an environment that is called an atopic person. And that when that atopic person passes on the gene to the next generation, some of those genes are going to be associated to other genes, for example, for asthma. So for asthma, you need a gene for atopy and a gene for bronchoconstriction, so the adrenergic receptor. So unfortunately, we cannot determine which genes you're passing on. You may be passing on